right, let's go ahead and get started here. So I am Carrie Nixon. I am the managing partner of Nixon Law Group, and we are going to be presenting today a webinar called The New CMS and FDA Innovation Models. Everyone has been talking about these. They've been the buzz of the healthcare innovation scene for a couple of months now. So we're going to focus on Access Tempo and MAHA Elevate. And we're going to sort of walk through what those programs are and what you can expect. Next slide, please. All right, so let's actually, we're going to start off by talking about access. My colleague Sam Pinson and I are going to be discussing the CMS access model. Michael Shellhouse is going to be talking about FDA Tempo. He is our FDA guru here at the firm. And Cindy Bailey and Mike Pappas are going to be talking about the Elevate model. So let's go to the next slide. All right, so we have to give our lawyerly disclaimer. We are all lawyers on this presentation, but we are not your lawyers unless you have signed an engagement agreement with us. So nothing said in this webinar is to be taken as legal advice specific to your company. Next slide, please. Okay, here we are. We will shoot these couple of slides out at the end of the presentation, just so you have a better sense of who you were talking to. We've got Sam Pinson, who is our AI guru at the firm, Michael Shellhouse, as I mentioned, with FDA. And let's go to the next slide. Mike Pappas leads our food as medicine practice and knows all things digital health. And Cindy Bailey is our newest and greatest addition to the firm, and she is also going to be talking about Elevate with Mike. Let's get started. All right, Sam, over to you.
Thanks, Carrie. So jumping right in here with the CMS access model, we're going to cover the players involved, reimbursement, and how digital health companies and providers can integrate alongside the access model. So what does access stand for? It stands for advancing chronic care with effective, scalable solutions. The vision here is to shift from a fee-for-service model to payments tied to achieving measurable clinical improvements via technology. We have a 10-year voluntary model via Access with an official launch for the first cohort on July 1st of this year, with applications due right around the corner on April 1st. The target patient populations for Access are Medicare beneficiaries with one of four specific chronic conditions, ECKM, so things like hypertension and obesity, CKM for things like diabetes, musculoskeletal, and behavioral health.
And I'll just say real quickly, I have heard a tremendous amount of excitement and optimism about this model. There's still a lot of things to be determined and finalized by CMS that are going to impact, who decides to participate and how. But people have been very excited about the notion of moving away from tracking minutes and tracking number of readings to just simply doing what's the right thing for the patient. So we hope that we will get there with the details and have a successful launch of this model, but it is a positive development for sure, I think.
Cool. So jumping into the various players within the access model, we've identified four core groups that are going to actively participate in access. The first are access management organizations. These are the entities that are assuming responsibility for the care of the patient. Part B enrollment as a provider or supplier is required. We're going to get into more detail on that concept later in the presentation. Second, you have referring and co-managing clinicians who are typically going to be your primary care practices or specialists. These groups are the on-ramps for the access model. They're compensated for referring patients into the program and coordinating care throughout a patient's time in an access program, which of course is another novel component of access. Third, we have the Medicare patients themselves that are on one of the four eligible condition tracks. Again, they can be referred by the referring or co-managing clinicians, or they can self-select into an access model provider that they prefer. And fourth, we have the digital health vendors, which can participate primarily through the tools directory, which is a marketplace of sorts for access management organizations, to implement and achieve outcomes through the services that digital health vendors may offer.
All right, next slide.
Okay, so jumping into access model reimbursement, we're going to cover how AMOs, referring and co-managing clinicians, and digital health vendors are reimbursed or incentivized throughout the access model program. So AMOs receive the outcome-aligned payment, which is the value-based payment. The OAP is divided into two portions, a 50-50 split. The first 50% is delivered quarterly after services are rendered, and the second 50% is withheld and reconciled based on clinical outcomes 1 year later. The payment is for results, as Carrie mentioned, not specific codes or time-based reimbursement. The referring and co-managing clinicians, again, these are going to be the primary care practices or specialists referring access patients. They can receive reimbursement in one of two ways. The first is a co-management fee paid at $30 once every 4 months per track. And then a separate initial onboarding and setup modifier to the co-management fee reimbursed one time at $10 per track. And lastly, digital health vendors that are not AMOs are not directly reimbursed through access by participating in the tools directory, but it is foreseeable that they would partner with AMOs to help the AMO achieve the value-based outcomes that they would be reimbursed for under the program.
And interestingly, we have sort of learned that CMS actually envisions some digital health vendors not serving just as vendors, but actually taking on the role of the AMO. If a company has been doing remote physiologic monitoring for a while and they really feel like they can move the needle on outcomes, we're seeing some companies like that really strongly consider moving into a direct care model where they're going to set up a services arm. They're going to be providing clinical services around the care management to the patients directly, rather than simply serving as a vendor to practices or to health systems as they may have done in the past. So I think that is an interesting twist that CMS has added to this, and we're looking forward to seeing, which vendors decide, which digital health companies decide to actually take on that model and participate as care providers themselves. Next slide, please.
So alongside reimbursement under access, there are a number of payment flexibilities that will be relevant to AMOs and practices as they implement the access model. Access participants may indicate in the model application that they will waive copays for patients enrolling in access. However, this must apply uniformly to all beneficiaries. And importantly, if an access participant elects to waive cost sharing, they must clearly disclose this to the beneficiary before enrollment. For the primary care practices and specialists that receive initial setup and onboarding and co-management fees, there is no copay for patients. The goal here was to support stronger collaboration between the technology-enabled care teams and traditional providers. Again, sort of serving as the rails and on-ramp to the access model for AMOs. And importantly, and lastly, CMS is making certain safe harbors to the anti-kickback statute available for various participants in the access ecosystem. Currently, they're making a safe harbor called the CMS-sponsored model patient incentive safe harbor available to access participants and that safe harbor enables them to waive these copays so as to not conflict or violate the anti-kickback statute. And interestingly, the safe harbor that is enumerated in the access model has two pieces. They've only explicitly allowed for the patient incentive component of that to be implemented, but we're waiting to see whether there are further expansions under the anti-kickback statute for the safe harbor to allow AMOs and other participants to offer additional incentives to onboarding.
Yeah, and I just want to underscore what a big deal it is to have CMS allow waivers of copays, right? It's hard to imagine that any AMO participating in this model will not take them up on sort of uniformly weighing the patient copays because that has been a real barrier to patients participating in care management programs before. For those of you who have implemented chronic care management services or behavioral health integration or remote patient monitoring, you know that collecting that copay on a monthly basis can be pretty burdensome. So that's a big deal. And then to underscore Sam's point about the safe harbor, we are really we'd love for CMS to sort of call out that the first component of that safe harbor is also applicable because that may provide the opportunity to create arrangements where the referring practice can actually receive some of the upside of that last 50% of the payment if the outcomes are achieved. So I think that would be a real benefit to sort of making this model work more effectively, having the referring practices really engaged and committed and involved that way. So we're hoping that CMS will clarify that a bit. Next slide.
So the next few slides, we're going to go into implementation considerations for each of the parties, starting with AMOs. As mentioned earlier, Part B enrollment is required to serve as an AMO under the access model. Secondly, there is a medical director requirement. Each AMO must designate a Medicare enrolled medical director to oversee patient care throughout the delivery of access services. And where this kind of, butts up against state laws through the corporate practice of medicine and the various implications thereof, which many on the call may be familiar with. But the corporate practice of medicine is a legal framework in many states that would otherwise prohibit corporations from practicing medicine or employing physicians, of course, serving as somewhat of a barrier to digital health vendors that want to be direct care providers under the access model. As an AMO, it's all but certain that you'll be practicing medicine incident to delivering access services. So corporate practice of medicine considerations should be top of mind. And bridging that gap to get to market as a digital health vendor is the MSOPC model, which is a strategic structuring choice that participants can choose to ensure that clinical decisions remain vested with licensed providers, even though they're technology-driven companies.
And that MSOPC model is what any virtual care provider or even sort of brick and mortar care provider implements if they are going to be in multiple states, right? If they're going to be seeing patients in multiple states, the practitioners have to be licensed and they have to have the appropriate sort of corporate structure in those states. And so it's sort of a complicated construct to get your mind around, but it is something that we see and we help implement pretty frequently these days whenever any kind of virtual care provider or hybrid provider is moving into multiple states. Sam's right. It is a little bit of a lift for the digital health vendors that decide to go into direct care, but for those digital health companies that really feel like they know how to do this care management really well, my guess is a lot of them will be deciding to do that. Next slide, please.
So next, we're going to cover some of the implementation considerations for digital health vendors that want to list on the Access Tools directory. First, CMS provided a list of certain types of digital health vendors that would be eligible. and fit for this program. Some examples include data exchange, interoperability solutions, identity verification, connected clinical devices, and other tools that support HIPAA compliance specifically. CMS will not endorse products listed on the tools directory, but it is a good opportunity to get your offerings in front of AMOs and other access model participants. Crucially, if you list on the tools directory, there is a self-certification of compliance requirement under frameworks such as FDA software as a medical device requirements, which Michael is going to touch on later in the presentation, HIPAA, of course, and also state law. Um, as a digital health vendor, you are always implicitly self-certifying that you'll be compliant with consumers and providers in the market, but listing on the tools directory may bring on some additional scrutiny, of course. And to incentivize digital health vendors to list on the tools directory, vendors may also choose to include optional promotional offers, such as discounts or service credits, to access participants, so long as they comply with applicable federal and state laws.
And this is a big deal for them to explicitly say, hey, we're going to allow you to provide these promotional opportunities for AMOs that you may be serving in this model. It is typically, those are pretty typically tightly restrained. And so, this is sort of another piece of evidence that CMS is really trying to incentivize great digital health companies from participating in the tools directory and helping these AMO models, the AMOs achieve their goals. Next slide, please.
So the last participant here in terms of access model implementation are the referring and co-managing clinicians. And again, to support the ongoing care coordination, engagement between referring healthcare providers and AMOs, clinicians who co-manage or do the initial onboarding will receive and can bill for the new access co-management service and the initial setup. So the requirements for billing the co-management and onboarding fee modifier are respectively placing an EHR note update related to access-related care and onboarding and initial setup activities. So, potentially helping the patient enroll with the access model organization. And one key opportunity for, primary care practices and specialists is, of course, leveraging all the new kind of AI-related admin tools to help make that care plan update and assist with initial onboarding.
All right, next slide.
Lastly, on the access model, rounding out with a note on data privacy and some enumerated requirements from CMS. The first of which is interoperability. Under the access model, there will be a mandatory use requirement of CMS-hosted APIs for clinical data reporting. And in terms of cybersecurity, there are a variety of specific device security and data protection requirements under HIPAA. So, some high standards for device oversight and data protection to participate in the access model.
All right, next slide, please. And before we jump to tempo, I'm just going to, we can stay on the slide, but I'm just going to say there are clearly some outstanding pieces of information that we are awaiting from CMS that will enable potential participants to make a really good decision as to whether or not they are going to participate in the access program. The key one that we keep hearing a lot about, understandably, is the quarterly the fee that will be prepared or that will be paid every 4 months or so to the access management organization, right? Sam mentioned that first 50% of whatever the payment is going to be will be paid at certain points throughout the year, with that top 50% at risk. So the key for all of this is, like, what's the total payment amount going to be? And that is the million-dollar question. And I think it's really going to decide whether this program flies ahead or stays kind of grounded. All right, let's move over to Michael Shellhouse to talk about the Tempo program, which is actually kind of adjacent to Access.
Yeah, thanks, Carrie. Exactly. So the Temple pilot really is kind of the FDA's companion pilot to go with the Access program. So this is the technology-enabled meaningful patient outcomes for digital health devices pilot. Really what it is FDA is trying to foster access to effective technology tools to improve patient outcomes while still safeguarding patient safety. At the same time, the program is designed to allow us, excuse me, to gather a lot of real world evidence about how these digital technologies are being used in the actual clinical workflow. That is going to be a benefit both to developers of these devices as well as to the FDA itself as it seeks to evaluate its current risk-based approach to digital technologies and try to fine-tune that to the technologies as we see them coming out into the market. So those are kind of our high-level goals as we go into the Temple pilot. So let's dive into it. We can go to the next slide. So to be eligible for participation in Tempo, first, the product, the device needs to be a digital medical device. What this means is that the goal of the Temple pilot is to allow products that can improve patient outcomes in one of those 4 areas of chronic conditions under the Access program, but that don't yet have FDA clearance for that specific intended use of improving patient outcomes with chronic conditions to still be able to be used. And so we have the fundamental requirement that it does need to be both digital, because we're focusing on the integration of technology into medical care, as well as a medical device. The important thing that I'll note here is that the definition of device under the Federal Food, Drug, and Cosmetic Act is based largely on intent. What is the intended use of the product? And so the things that have traditionally fallen under general wellness categories, things like wearables and things like that, the reason they're excluded and they don't qualify as medical devices is they're not intended to be used in medical use cases. They are intended for non-medical use cases like exercise, like general wellness tracking and things like that. So those products could qualify as medical devices for purposes of the Temple pilot if they add clinical claims. If they're adding on the claim that our product can now improve outcomes for patients in one of these areas of chronic conditions, that is now a medical claim. And so you can qualify as a medical device under that, even if outside of that use case, you're traditionally fitting into one of those exempt areas like general wellness. The second requirement that we have is related to the risk that the device can provide to patients. The standard that we have for Tempo is that no potential serious risk to the health, safety, or welfare of patients is presented by the device. An important note here is that this is a different standard than what we see for the FDA's exercise of enforcement discretion in general for low-risk softwares and medical device products. The standard there is that there's no risk at all to patients if the software malfunctions. So we see a lowering of that standard a little bit here, where now we're only going to have an issue if there's a potential serious risk presented. So it does give us a little bit more leeway, but it is more of a targeted application of enforcement discretion within the pilot program. And so we're not going to see the broad discretion that we see under normal SAMD enforcement discretion. And the last eligibility point is that the device does need to be intended to be used in conjunction with clinician supervised outpatient treatment in one of those 4 clinical use cases under Access. The point here is really is that it can't just be a standalone thing. It does need to be fully integrated into the workflow to improve patient outcomes as part of the ongoing treatment of that patient. All right, we'll go ahead and go to the next one. So let's say that we have a device that is eligible. What logistically do we need to do to participate in the program? The FDA is anticipating that they are going to permit about 10 devices per Access pathway. Again, we have those 4 different clinical use areas under Access, so we're looking at potentially about 40 devices. A lot of devices, though, could potentially be applicable under multiple tracks. So we don't know exactly how that's going to play out. So there may be slightly more, maybe slightly less than 40, but we're looking at that as the ballpark of what the FDA is going to put into this pilot. Logistically, the first thing we want to do if we're interested in participating in the Tempo pilot is to submit a statement of intent to the FDA. Those statements are just submitted via email to the FDA address that's listed on the screen there. And these are intended to be pretty high level. It really just says, this is who I am. This is the device that I have. This is how my device is intended to be incorporated into clinical workflows. Here are the medical claims that I'm going to make with it. And we're going to request that the FDA exercise enforcement discretion while we continue to prepare to get FDA approval for this intended use that we don't have clearance for yet. The two key things there is that the FDA is, however, going to want that proposed statement of indicated use, indications for use. That's going to be a key factor in how the FDA looks at the rest of the device's integration into the pilot, how it's used under access. That's where you want to be very careful about how you're framing it and what claims you're making. That's probably the biggest key thing with that statement of intent. The FDA doesn't have a hard deadline on when you can submit a statement of intent, but they are going to start responding to people on March 2nd. So if you are interested in the Tempo pilot, make sure that you submit prior to that point. If you have any questions about, what an appropriate indications for use statement would be for your intended use of the device, reach out to someone to help you draft that. We've helped a lot of people with that in the past, so make sure that you've got that nailed down so that you can be considered by the FDA for that initial follow-up. We can go to the next slide. So once you've submitted your statement of intent, the next thing is, as the FDA looks at all the applications that have come in, they're going to start reaching out to ones that they feel could qualify pretty well under the program. That's where we're going to have these more detailed conversations. That's where the FDA is going to require detailed information about safety data for your product to make sure that we're not presenting any potential serious risk of harm to patients. They may ask for your risk analysis that you've done for your device, your risk mitigation and clinical use plans, data about the quality management system that you've built for your device. And then they're also going to want to see some detailed proposals about your performance goals under the access program, statistical analysis plans, and then reporting plans. Remember, you have obligations to report both to CMS and to FDA if you're under the Tempo pilot. So they want to make sure that you've thought that through and how is the data flow going to occur and what kind of data can they expect. These are going to be much more detailed conversations, as we said. If this is something that your device hasn't done previously, doesn't have ready to go because you haven't submitted to the FDA before, start early preparing for these conversations. Start early gathering the data, collecting your risk analysis, your statistical analysis plans. That can take some time. The FDA is probably going to want to move pretty quickly because, as we see, the initial part of access is intended to start in just a few months. And so the FDA wants to see data prepared and ready for these conversations. So don't delay these. If you have questions about how any of those go, make sure you reach out to someone who can help walk you through that. Don't feel like you have to do it alone, but make sure you're ready for those conversations. Okay, we can go to the next one. So once we get through all of the initial application period, we've gone through those detailed conversations with the FDA. What does participation in the pilot actually look like? There's a couple of key points here. One is enforcement discretion. That's the key purpose of the pilot. Again, this is for devices that want to be used to improve patient outcomes for chronic conditions under access, but don't yet have FDA clearance for that particular intended use. The FDA has said that it will waive certain pre-market authorization requirements for those participants, but it's going to do so on a device-by-device basis. What that means is, in those detailed discussions that you have with the FDA, they're going to look at the risk analysis plans that you have, your risk mitigation and clinical use plans, and they will determine which device requirements they're willing to waive and which ones they are going to hold you to. As you prepare for that, you need to know which ones you can easily meet and which ones are going to be a problem. How do you address that with the FDA? How do you address any concerns they have about risk mitigation under those waivers? Understand that that's going to be device specific. And so you want to be able to have a nuanced conversation with the FDA and get them to waive what you really need to start gathering data, which is the second key thing. Participants in the Tempo pilot will be gathering real world data, and they have to pass that data back to the FDA. This is partially to ensure some of that risk mitigation and patient safety is occurring. This is also, again, to help the FDA see how these technologies are being implemented in the actual clinical workspace and be able to adjust their enforcement strategy based on the data that we have coming back. Now, that real world data, if it's appropriately analyzed and the FDA accepts it, may be transferred into real world evidence that can support a submission to the FDA. The FDA does expect that every participant in the Tempo pilot will go to the FDA for formal approval for that indication for use. So that enforcement discretion that we have under this is going to be temporary. And to help with that, the FDA will engage in sprint discussions with participants to help them prepare for future market submissions. It could be, discussions about the adequacy of the data that you have, any other concerns that they have. They are going to want to see you move forward toward that formal submission, though. And so we have this massive benefit of being able to have these candid conversations with the FDA and these sprint discussions to figure out how to get there quickly. Okay, we can go to the next one. So what is the overall impact? This is a huge benefit for digital health technologies that are going to participate in this. It does create this collaborative environment within a regulatory sandbox where you're able to get real input from the FDA about the data that you're collecting. You're able to collect real world data that can translate into future submissions, can be the basis for pivotal studies in the future, things like that. It's a wonderful opportunity to inform the FDA about how your technology works, what risks are actually presented, what risks are not there, and allow them to modify how they're going to approach your device based on this sandbox that we have for it. It also allows a really important strategic market alignment. When we see this shift away from fee for service, we see the integration of these technology tools that can improve outcomes. It's sometimes difficult for new technologies to get buy-in from providers when they're not getting reimbursed for the specific device. If we have this real world data that's able to show, look, my device does improve outcomes, this is going to be important for your outcome aligned payments, it really helps move the market forward and helps align with provider interests. And lastly, this is a huge on-ramp for emerging technologies and wearables. Again, regulation of devices is based on intent and intended use. And we see a lot of wearables collecting a lot of very valuable health data, but there's that break between the health data collected and the medical claims that it can help with. This is going to provide a huge bridge for that and allow the FDA to consider, how do we bring that health data in? How can we use it in real world to advance patient outcomes without really, giving up too much in the patient safety area?
Yeah, I
So we
think this
can
is really solving like the chicken and the egg problem that device and software as a medical device manufacturers have experienced, right? Where they can't get the data because they can't contract with the health systems because the health systems want them to be FDA cleared, and they can't get the clearance without the data or the funding. So that is very exciting. I will also say I was sitting in on a bit of the Assistant Secretary of Technology Policy annual meeting this morning, and it does seem that FDA is taking a very pro-innovation stance. It seems like they are inclined to allow some devices to be in market that definitely would not have been allowed in market previously. And so, that there is an opportunity there, right? Everyone needs to be responsible in the market, but CMS or FDA, excuse me, it does seem to really be taking sort of a pro-innovation approach. And if guardrails are in place, they seem to be willing to let these digital health platforms run.
No, absolutely. And one of the interesting things, as you said, is there's also often a difference between the way that technologies can be implemented in a very closed, structured clinical trial versus how it actually works in the real world. And so the FDA is very interested in viewing that because they want to see this innovation, they want to see these things come out, but they don't have enough data to feel comfortable doing that. And this is a way for them to get that data, to get comfortable with having new approaches to these technologies. And I think it's going to be fantastic. Hopefully, fingers crossed, right? All right, we can jump to the next one. So this is really just kind of a compare and contrast. Access and Tempo really are intended to work hand in hand. Access is the payment model to improve outcomes for chronic conditions. Tempo is the way that devices can be used in that, even if they don't have official clearance yet. You can see the regulatory flexibility versus the payment innovation. CMS and FDA are often dealing with the same questions and problems, but they come at them from very different perspectives. And so this is an important way that we see them trying to align those perspectives in a way that can move the market forward in a meaningful way. And so I have hope that we'll see progress here and that we'll see good data come out of it to push things forward. And we can go to the next one. We have just here for you some key deadlines to keep in mind. January 2026 is when the access applications opened. March 2026 is when the FDA is going to begin follow-up for those that have submitted interest in Tempo. And then we see April is the application deadline for first access cohort. You see some of the other deadlines there. If you are interested in access or Tempo, we don't have all the details yet, but don't delay. If you're interested, submit your interest, make it known, make your voice heard, and then as additional details come out, we can work with CMS and FDA to figure out how to implement it.
And Michael, we do have a question from an attendee asking whether the Tempo pilot is open for application. My understanding is that it is open. Is that correct?
Yes, yes, it is. So that also opened early January. There is no deadline to when you have to submit. Again, there's not a portal or anything like that for Tempo right now. You just submit that statement of intent to that FDA email address, and that's how they will put you into their consideration for follow-up.
Great. All right, let's
And
move. Go ahead, Michael.
yeah, I was gonna say we can go to the next one. Just very high level, some of the key takeaways. Access and Tempo together really does indicate this kind of paradigm shift that we're seeing from fee for service to outline payment or outcome payment alignments. And this is really a strategic advantage for all the technology vendors that are coming into this. There are huge benefits and opportunities to really leverage these for additional leeway with the FDA and to get market access. Carrie, I'll let you jump in with your thoughts with that. I could talk about that for a long time. I don't know what
I
we
know,
can do.
all of us could. I agree fully, but I'll let us move along. Yeah, we'll see how these outcome aligned payments shake out, what the pricing is going to be, and we'll keep our fingers crossed that it's enough of an incentive to get a lot of participants here because it's going to be a neat model. Let's move on to Elevate. All right, and Cindy and Mike are going to be talking about Elevate. We'll turn it over to them.
Thanks, Carrie. So now we're on to part 3 of the webinar, the MAHA Elevate model. Now, it's not as integrated and similar to Tempo and Access. It's a step away, but it's really a Medicare coverage expansion by demonstration. A long time coming for some of us to see this happen. Although when CMS introduced the program and announced it, it called it the unglamorous work of prevention. I think it's pretty glamorous, but it's an interesting approach that we finally get to test and demonstrate whether preventive measures should be covered by Medicare. So the word elevate means enhancing lifestyle and evaluating value-based approaches through evidence. The focus is on evidence. So, and we'll go through the program requirements and then identify some legal considerations for this whole person care in Medicare. So, next slide, please. So, it's a CMS Innovation Center program, and as I mentioned, the focus is on the whole person. Functional and lifestyle medicine interventions that are not currently covered by Medicare. Importantly, you do not need to be enrolled in Medicare as a provider to be eligible to receive the funding under this program. Quite different from Access and Tempo. Now, the target conditions, chronic disease prevention, the awards will be reserved for dementia. That's important as a recognition of a priority focus of the government and the country on dementia. So it's a cooperative agreement. So not paid by Medicare. Hopefully, some of these will be demonstrated in a way that Medicare reimbursement will become available. It's $100 million total available for 30 awards over 3 years. There's 2 cohorts, one for 2026 and one for 2027. The Notice of Funding Opportunity, also called a NOFO, is expected very soon. Now, as of about an hour ago, it's not been issued yet. It could be issued at any minute, and the application window will be tight. We'll post something on our website or LinkedIn to let you know when the NOFO drops. But just keep in mind, it could be any minute now that you may want to start preparing and submitting the application. The application will look like a grant application that's similar to receiving any funding for programs that are health related, ancillary, but not what you see in Medicare. So the NOFO is to quote Carrie, one of the outstanding pieces of information that we need, because that will really give us more detail on the requirements and the obligations of the awardee. So, as I said, let's start preparing now, though. The application window will be tight. So, next slide, please.
All right. Thanks, Cindy. So, as Cindy mentioned, this one, there's definitely some similarities, and certainly this is through the CMS, CMMI, but there are also a lot of differences. According to CMS, this model, this MAHA Elevate, they say it's the first innovation center model to focus on this proactive, holistic approach. So, something different, which is great. And it does have some essential components, although I'm sure we'll get more details with the NOFO, but here's what we know so far. So all of the up to 30 recipients will need to include nutrition or physical activity as part of the proposal. So it can have, of course, many other things, but those are required in all proposals. And for the 3 that are reserved for dementia related, they can be layered with the guide model. That's an 8-year program that was launched in 2024. So that's already in place, but that can be layered on. And then additional focus areas can include sleep, stress management, harmful substance avoidance, or social connection. So really a broad list to really get into that functional and lifestyle medicine approach. But there are some requirements that, of course, this is a CMS and those federal data and fiscal requirements. The recipients would have to demonstrate prior experience with evidence-based interventions. So, think data-driven quality initiatives. Also, scientifically documented health improvements. So I think of this as clinical research, ability to either with experience or to partner with those who understand clinical research and peer-reviewed data analysis for healthcare interventions. And then data collection and reporting capabilities, being able to not only collect, but report and use CMS-approved APIs, comply with data security and privacy requirements as well. Next slide, please. So as Cindy mentioned, there are some similarities and differences compared to access in general Medicare. So one is providers for this, recipients do not have to be Medicare providers. So Medicare enrollment is not required to be one of those up to 30 recipients who deliver these services. They could be, so you could be an AMO or a Medicare Part B supplier, but you don't have to be. So you have a really broad range, and CMS lists some examples in addition to your private medical practices, ACOs that you would typically see. It could also include governments, academic organizations, senior living communities, and so, and broad-based of community-based organizations. So a lot of opportunity to expand beyond that traditional barrier of I'd love to do this, but I'm just, I'm not a Part B provider or supplier, I can't be, or I don't have a partner. But the people served, the patients need to be traditional Medicare beneficiaries. So not Medicare Advantage, Medicaid commercial. The target would be similar to access would be the Part B original Medicare patients. So you have broader provider types, don't have to be enrolled in Medicare, but the focus is Medicare patients. In addition, compliance with HIPAA is mandatory. So even though you're not potentially a Part B supplier, you do have to comply with all of the HIPAA requirements, sort of like you're a covered entity or business associate. So there are some strings attached. Next slide. So we have a lot of unknowns while we're waiting the NOFO. So one thing is we know there's up to 30 awards and $100 million reserved, but what are the award size ranges? What if less than 30 are approved? How is that going to look? Will some be small and some large? Are they going to be evenly split? How is this going to look? And we don't really know how the funding is going to look across the cohorts. So is it going to be front loaded? They're 3 years, but the cohorts are over 2 years. So you have cohort 1 this year, cohort 2 next year with a 3-year delivery period. And so we don't really know if it's going to be front loaded, what those options are, and if there's any certain minimums or maximums. Also, the dementia reserved awards, will they have different funding levels? If they're already doing this under guide, for example, does that matter? And how will those be integrated? So a lot of these will come out, and hopefully the NOFO, maybe it'll be released today. It should be any time now, but we'll learn a little bit more when we actually get there. But the good news is this really opens the door to a lot of the things that, through MAHA and others we've been talking about, to have holistic, value-based care, preventing chronic disease, even if it's not preventive, getting it early on. So this opens the door for, nutrition care, because in Medicare, when it says it has to be, non-covered services, keep in mind Medicare covers very little in the nutrition sense outside of chronic kidney disease and renal disease. That would be a non-covered service. So those are opportunities. And while it doesn't cover food specifically, all of the data collection, administration, all of those things are included. So there's still, that's very expensive. A lot of that education and outreach and cooking classes, for example, all of those things would be included, just not the food itself. But occupational therapy, functional medicine, labs tons of labs aren't covered that can be combined with preventive care, nutrition, physical education, just so many options that are just off the table right now. So very, very exciting. Next slide. Turn it back to you, Cindy.
Thanks, Mike. So I mentioned at the start that this is not a Medicare billable service that we're talking about. It's not fee for service or some sort of value bundled service. This is funded through a grant. And how that grant is characterized and the funding you received is called a cooperative agreement. Now, some of you listening today may be familiar with grant funding, but traditionally, healthcare providers, other than perhaps in academic medical centers, don't have a deep understanding of what a cooperative agreement model would look like. So now there is still compliance obligations. Some of them are similar to what you would see in a fee-for-service or bundled situation, but there are some differences. So one concern that often arises in grant-funded projects when they're adjacent to healthcare is double dipping. What do I mean by that? You may have a grant that funds something related to diabetes prevention, or diabetes really management. And yet you get reimbursed for example, diabetes services and renal dialysis situations. So you can't use the funds to pay a nurse to you and bill for her. So that's a good example. You've got a nurse that's performing services to care for a patient on dialysis, but she's also her salary is being supported by the grant fund. So what do I mean? You have to build a clear operational wall if you're someone that does bill Medicare, a Part B provider, and also receive the grant funding. Now, one thing I didn't mention was this program, Elevate program, actually allows you to submit multiple proposals and to potentially receive multiple awards. But I think that's a distinction that's interesting too, that our audience would want to know. But segregating the activities from Medicare reimbursable ones is key, and you'll need a cost allocation model that would withstand an audit. That you have two clear buckets, and we're not pouring money from one into the other. So next slide, please. So although it's different, there's still False Claims Act exposure. You're receiving funds from the federal government. There are strings attached. So it's the same flavor, but a different kind of teeth. Well, actually, it's same teeth, different flavor. Sorry. There's when you fill out the application, everything has to be truthful. You will certify to the truth of that. And if you make a false statement in the application, that would be considered a false claim under Federal False Claims Act. You can't misrepresent the progress or the outcomes that the funding is achieving. Again, a false claim. You can't charge unallowable costs. You have to stick to the four corners, if you would, of the grant document when you're using the funds. And you can't make any false certifications of compliance with the award requirements. So when you submit the application, it's can be a sometimes very intimidating document if you haven't been involved in grant funding before. And it's something to sit down and go through carefully, because if you, in fact, can't comply with stated in the grant and you do sign it, it's a false claim. So, next slide, please. Now, the anti-kickback statute and Stark laws, they're still lurking here, even though they're not a Medicare Part B reimbursable service. So, as I said, if you are a Medicare Part B provider and you receive a grant under Elevate, any referral relationship with partners could still implicate the anti-kickback statute and the Stark law. So partnership, when you have a partnership structure or considering one, when you're applying for a grant, for this grant, you really have to proceed with caution and structure it compliantly. There are some tricks, traps, and they may be something you're not familiar with. Partnership structures, I believe, will be important in demonstrating how the potential of the funding that you would receive. However, something to really keep mindful of when you are looking at that, and to talk to people that can help you. So the OIG, still looks at arrangements where grant funding services create referral streams for Medicare reimbursable services. In fact, it's and one of the reasons is it's not always thought about. And Elevate promises funding for things that, as Mike said, hasn't been funded in a strong way before. But there are these precautions that you need to take and be aware of when you are filling out that application or applications. Next slide, please. So, Mike,
Yeah,
next
thanks,
steps.
Cindy. Yeah, so right now we're still waiting on the NOFO, but in the meantime, we have a QR code here you can scan directly. You can subscribe to the MAHA Elevate listserv. So you can get daily or live updates, and likely one of those updates will include the NOFO coming out, hopefully. And also now you could assess your existing programs and partnership opportunities. So, just the planning phase is really important here, because it's not just singular organizations. A lot will be partners, especially given how new and different this program is. And when the NOFO drops, review the eligibility and application requirements. I mean, they're going to be a lot more detail, and certainly you want to get into the fine print, and certainly engaging in your legal consulting experts to review and the partnership structuring, all of the terms, the financial obligations, data requirements, all of that you can make sure you can actually comply with them. And if awarded, building the internal governance structure. So it still is, federal payments. So as Cindy mentioned, all of the, AKS and, obligations are there, and risk is there as well. And so you want to make sure your HIPAA compliance and general healthcare compliance is in order. So that's Elevate in a nutshell. Next slide.
There we go. Okay, so thank you everyone for excellent presentations. We've had a ton of questions come in through the chat, and a lot of them have been answered by one of us typing in answers, but I do want to respond to a couple of them live here. One that I want to read is, can you touch upon the prohibition of the AMO, the Access Management Organization, to bill Part B for other Part B services, and the degree to which this serves as a practical block to established providers and health systems to be AMOs? I wanted to answer this live because it's complicated and I didn't even want to begin typing it out. So it is the case that CMS has specifically said that any physician or entity that has more than 5% ownership in an access management organization cannot bill fee for service. And It is also the case that CMS has confirmed in conversations with stakeholders that they didn't really anticipate the access program to be used by health systems. They are more thinking about this as a program where referring physician practices will be involved. And so, you know, the point of sort of this prohibition is, I believe, to really focus the access management organizations on care management, like very, very specifically. And so they don't necessarily, what they don't want to do is they're certainly prohibiting access management organizations from billing remote physiologic monitoring codes or chronic care management services codes. It is also the case that if a referring practice refers a patient to the access management organization, that referring practice should not be billing for RPM or for CCM either on the fee-for-service front. That would be sort of double dipping, and both entities, I believe, would be penalized. Certainly the AMO would be penalized. So yes, it is, this prohibition for AMOs billing Part B services. I think it's largely targeted at the care management service CPT codes, but it is going to be sort of a blocker for things like for entities like health systems to participate. All right, let me go through real quickly and see what else we have. Does the prior experience requirement exclude startup companies with a pre-approval product? And I think this was with respect to the Elevate program. Mike or Cindy, you want to take that?
Yeah, me some prior experience. I mean, yeah, so some of it could be, it doesn't have to be specific to one exact product, but more of general experience in terms of data collection, reporting, how these studies work. It doesn't mean you have to have an established, your service, if it's innovative, has to itself be established. It's more of establishing it. Now, of course, it does have to be safe, and to the extent there's effective or studies that show it is so, but it's not a preclusion just because it's a new or innovative treatment or product.
Excellent, thank you. We also had a question as to whether the slides and the recording will be shared. The slides will not be shared, but the recording will be shared. So you will have that. I'm just flipping through to see if there are any other questions. Okay, is there a mechanism for digital health solutions to get into the tools directory? Yes, there will be a mechanism for any kind of digital health solution to be listed in the tools directory, as long as they are certifying that they are compliant in the ways that CMS has laid out. That CMS hasn't made that sort of directory application available yet, so stay tuned. I would recommend that if you want to be listed in the tools directory, you express your interest specifically to the access program, and they will be sending out email updates when things like, registration for the tools directory comes about. Let's see what else have we got here. Again, a few people have commented on the outcomes aligned payment, the OAP, and what that, there is great interest in what that rate is going to be. We don't know yet. My personal point of view is that if it's not significantly higher than what one could achieve with the fee-for-service care management codes, either on their own or in combination, that people are not going to participate in this model, and it will not be a success. So, the hope is that CMS recognizes that and will, appropriately incentivize participants. Team, do you see any other questions that we should close out with? I think we've covered the vast majority.
I'll follow up with one,
Michael,
Mary.
go ahead.
Yeah, there was just one. There was a question about if you already have FDA clearance, do you need to worry about tempo? It's a good question. It really comes down to the intended use that you have been cleared under. So the FDA has made the point that tempo is going to apply to devices that have FDA clearance already, but that clearance doesn't contemplate an intended use of improving outcomes for chronic conditions, or if you don't have clearance yet. So even if you do have FDA clearance, it's something to be aware of and look at what the scope of your clearance is. It may give you leverage to be able to expand the claims and expand your market access through that. So.
And I see a couple of other questions that we will stay on to answer here. One is, would an existing approved Part B provider apply to Access as a provider or an AMO? So an access management organization is required to be a provider entity enrolled in Part B. There's no prohibition on an existing entity, an existing practice, applying to be an access management organization. It's probably unlikely that a practice would go fully to the access management organization, like an existing practice would, become an access management organization. My guess is that most people will form a separate Part B entity, but it's certainly not required. I think there was one other one. Okay, costs related to the provision of access care are not counted toward Medicare's shared savings programs total. So we should separate out access from any type of Medicare shared savings program. CMS has sort of indicated that they expect health systems are going to sort of take on the LEAD model that they released just before the end of the year, LEAD. I don't remember what it stands for. There are so many acronyms right now. But that's sort of the ones that they're anticipating that health systems are more likely to participate in. And I know that they have said that the expense associated with care management CPT codes will not be attributed to and sort of counted against the ACO. And I think we've covered mostly everything that we can cover at the moment. So thank you so much for joining us. Please reach out to us if you have any questions. Again, you will have this recording, but we are happy to help, and we are looking forward to seeing how these various programs progress, and hopefully they will be incredibly successful. Thanks, everyone. Have a great rest of the day.